heroin addiction and abuse is very boards relevant. It's important to know that the use of injection drugs will predispose patients to a wide variety of diseases. The more obvious ones include AIDS and hepatitis, but the trickier one can include things like endocarditis. So let's look at what they're at risk for. Hepatitis, abscesses, overdose, hemorrhoids, AIDS, and right-sided endocarditis. Why the hemorrhoids? That's related to the hepatitis and increased portal hypertension. Now, do you remember from the cardiovascular lecture why this will be right-sided endocarditis? That's because the bacteria being injected from the IV into the veins are going to go to the right side of the heart first. So what are the treatments for heroin addiction? Long-term control for patients with a history of opiate addiction is classically achieved with methadone. The other new options include Suboxone, which includes a partial opiate agonist called buprenorphine, and naloxone, which is an opiate antagonist. The naloxone portion is not active when taken orally, so withdrawal only occurs if someone tries to inject the drug with the hopes of getting a sudden and rushed high feeling from the intravenous buprenorphine instead of taking it orally, in which case the buprenorphine is more slowly introduced into the bloodstream, meaning Suboxone is meant to be taken orally. So it slowly goes into the bloodstream and doesn't give the person a high feeling. And the naloxone is not absorbed. But if someone tries to inject Suboxone because they want to get a sudden rush of buprenorphine to get a high feeling, they'll actually get a withdrawal, because now the naloxone is in the bloodstream and you're going to get the opposite effect. You're going to get a withdrawal effect. You're going to feel terrible. So combining these two drugs reduces abuse potential for the patients and also decreases withdrawal symptoms as long as they're taking it orally. Naltrexone is a long-acting opioid antagonist used for the maintenance phase of overcoming heroin addiction. Now, in the context of clinical vignettes, as we previously mentioned, be suspicious of heroin abuse in patients with pinpoint pupils. Phew, that was a marathon. Let's talk now about something that is more boards and wards relevant because it is so common. Now, that entity that we're going to discuss is alcoholism. And let's start now by defining alcoholism. It is the physiologic tolerance and dependence that comes with continued alcohol use, and it's associated with the symptoms of withdrawal when intake is interrupted or the alcohol is not consumed regularly. Now, those withdrawal symptoms, like we mentioned earlier, include tremor, tachycardia, hypertension, malaise, nausea, and delirium tremens. The complications of alcohol include alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, and testicular atrophy. Treatment for alcoholism includes disulfiram, which makes the patient feel very unpleasant if they drink alcohol. How does it work? It's inhibiting the actions of an enzyme. That enzyme is acetaldehyde dehydrogenase. And it's causing acetaldehyde levels to build up when alcohol is being metabolized. And acetaldehyde is a toxic byproduct that makes the patient feel awful and therefore conditions them not to drink alcohol. Now, as you can imagine, it's quite difficult to maintain compliance with a medication like this. No one wants to feel awful, especially when they want to drink more alcohol. Now, disulfiram is not as boards irrelevant medication just because most patients don't want to use it. But you might remember there are other drugs that have a disulfiram-like reaction. Can you remember a few? They are metronidazole, some of the cephalosporins, and the first-generation sulfonylureas. Another treatment for alcoholism is naltrexone, which is an opioid receptor antagonist that reduces relapse in alcoholics trying to quit. Supportive care and peer support groups like Alcoholics Anonymous have also shown to be effective in helping patients quit their alcohol abuse. One of the main clinical entities associated with alcoholism is Wernicke-Korsakoff syndrome, which is caused by thiamine deficiency, also known as B1 deficiency. Now, as you may know, this syndrome has two separate triads in it. The first is Wernicke encephalopathy. And now, why do I say triad? Because there's three symptoms that really summarize this whole entity. And those are confusion, ophthalmoplegia, and ataxia. Now, if it continues, Wernicke's can progress to Korsakoff psychosis, which is also a triad, and it's characterized by irreversible memory loss, confabulation, and personality changes. So, pathologically, it's associated with periventricular hemorrhage and a more pathognomonic finding of necrosis of the mammillary bodies, which can be seen on MRI. Now, this can be treated by IV thiamine, which only really works if it's caught during the stages of Wernicke encephalopathy. Once you get to Korsakoff, it's irreversible. Now, administration of a large dose of glucose in the setting of subclinical thiamine deficiency can actually precipitate Wernicke encephalopathy. So, glucose should always be given with thiamine in the setting of potential thiamine deficiency. Now, why is that the case? Well, remember, thiamine serves as a cofactor in glucose metabolism. So, if a large amount of glucose is given, say for someone who has a low blood sugar, but you're also concerned that they might have low thiamine, you want to give thiamine when you give them glucose, because if you give glucose without thiamine, their thiamine levels are going to be further depleted as the body uses up its little stores of thiamine to metabolize that glucose. Another disease associated with alcoholism is Mallory-Weiss syndrome. This occurs because patients suffering from alcoholism often vomit profusely, which causes longitudinal, superficial lacerations in the gastroesophageal junction. And the lacerations often cause bloody vomit or hematemesis. In contrast to cirrhotics, which present with variceal bleeds, hematemesis is associated with pain and often resolves spontaneously with no intervention, while variceal bleeding, on the other hand, in cirrhotics, will require endoscopic treatment along with pharmacologic therapy. Now, what is the biggest thing you have to worry about when it comes to alcohol withdrawal? They are delirium tremens, DTs. It's a consequence of alcohol withdrawal that is potentially life-threatening. The risk of DTs peaks from 2 to 5 days after a patient's last drink. And the initial symptoms show autonomic hyperactivity, and this includes tachycardia, tremors, and anxiety. Then, as it progresses, patients will exhibit psychotic symptoms, including hallucinations, delusions, and finally, confusion. Now, do you remember what kind of hallucinations patient with alcohol withdrawal will experience? The answer is tactile hallucinations. Tactile. Remember, formication, the feeling of ants crawling on your body. That is the type of hallucination that patients undergoing alcohol withdrawal will experience. Now, the main treatment for DTs is benzodiazepines. It's important to give alcoholics who are acutely abstaining from alcohol benzodiazepines prophylactically to prevent DTs. So, great job. Let's finish with some questions. A parent notes his daughter has been socially withdrawn and is eating more. Her mouth is dry. What drug is she abusing? Answer is marijuana. Remember that it causes dry mouth, social withdrawal, and increased appetite by stimulating the cannabinoid receptors in the brain, which regulate appetite, and that's why this girl is eating more. Okay, let's test ourselves. A 24-year-old woman is referred to a psychiatry clinic as part of her parole agreement. She has a long history of legal trouble and has been incarcerated for most of her life since age 15. Her most recent imprisonment was the result of a robbery in which she assaulted one of her victims. When asked why she did this, she replies, "That's the way of the world. You can't trust anybody. If you want something, you've got to take it no matter who you hurt." Which psychiatric disorder did this woman most likely have when she was a teenager? A. Attention deficit hyperactivity disorder. B. Conduct disorder. C. Oppositional defiant disorder. D. Separation anxiety disorder. Or E. Tourette syndrome. The correct answer is B. As an adult, this woman would be diagnosed with antisocial personality disorder, which is marked by a disregard for the rights of others and the rules of society. So that's as an adult. But under the age of 18, behavior that violates social norms such as hurting animals, setting fires, and stealing is seen in children with conduct disorder. Now, remember that the evidence of conduct disorder occurring before age 15 is required for the diagnosis of antisocial personality disorder as an adult. So A is not correct because ADHD is characterized by emotional lability and impulsivity. C is not correct because children with oppositional defiant disorder do not comply with an authority figure's request, but they're still able to feel guilty for their own actions and have empathy towards others. D is not correct because separation anxiety disorder usually arises around age 7 and is characterized by clinginess and fear of loss of an attachment figure. And finally, E is not correct because Tourette syndrome is characterized by involuntary, repetitive motor or vocal tics. So, great job. I'll see you next time.